Good afternoon, everybody, and welcome to Grand Rounds. My name is Yates Conwell. I'm a professor of psychiatry and co-chief with Drs. E.J. Santos and Anton Thorstensen of the Geriatric Mental Health and Memory Care Division. And we're really pleased to host this Grand Rounds today and the visit by Dr. Lisa Barry, who's a good friend, colleague, and collaborator from the University of Connecticut, who will be talking to us about her really fascinating studies of aging in place inside prisons. Before we get to that, though, and I'll introduce Dr. Barry in a minute, we need to do a few housekeeping items, as usual. The first is to note that all mics and cameras are going to be off, except for the presenters and the interpreters during the course of the session today. We do want to and plan to leave plenty of time for questions at the end. So please note to put your questions in the Q&A box on the toolbar at the bottom for that purpose at any time during the course of the presentation, not in the chat box, because we keep that for chat between interpreters and around technical issues. So focus your questions in the Q&A box, please. We look forward to collating those, and then at the end of the session, I will be asking Dr. Barry those questions for you. At this point, also, we'll post a link in the chat to the form for you to fill out to get your CE credits, and we encourage you to use that. There'll be a link at the end of the presentation for that as well, and an email that we'll send out with that link in the next day or so to be sure you have that opportunity. At this point, let's turn then to the presentation, and it really is a great pleasure for me to introduce to you Dr. Lisa Barry, who is a tenured associate professor in the Department of Psychiatry at the University of Connecticut. She received her undergraduate degree at Holy Cross with a certificate in gerontological studies at that time, and then moved to Yale, where she received her Ph.D. in epidemiology, as well as her master's in public health degree, and stayed for a postdoctoral degree training program there in geriatric clinical and research epidemiology. In 2011, she moved to the University of Connecticut, where she's moved up through the ranks and is now an associate professor in the Department of Psychiatry there. Lisa and I first met in 2011 when we both were attending the Advanced Research Institute for Geriatric Mental Health Research, and already an expert in aging and function. Dr. Barry lit on during that time the idea of applying her background and skills to the study of aging in the prison population. Now, this is a pretty unusual topic, and she's really a recognized expert in that area now internationally. And it's fascinating not only for the nature of the findings that she has and how she can help us understand the relationships between aging in that particular context and factors like functional impairment, depression, other mental disorders, and suicidal ideation, but also for the lessons that it teaches us, I believe, about aging more generally, the role of functioning and context in the determination of suicidal ideation and behavior in later life. She's a prolific author with over 40 peer-reviewed publications and a couple of major grants from the National Institute of Mental Health revolving around this issue of aging and the prison population, both inside the walls as well as in transition back into the community. And as she'll explain, this is an increasing issue of major public health concern. So with that background, let me turn it over to you, Lisa, and welcome to Rochester.
Great. Thank you very much for that kind introduction, Yates. Okay, so I'm going to start by just briefly describing mass incarceration in the United States. So in the United States, at any given time, there's more than 2.2 million people who are incarcerated. However, more than 11.5 million admissions actually occur annually. So there's in jails. So there's a lot of jail churn. The US has 5% of the world's population, but it incorporates 25% of the world's prison population. So a large number of our population is incarcerated. Sorry, I'm having trouble advancing. Sure what the problem is. Oh, here we go. All right. So who are the incarcerated? Most of the time when you think about people who are incarcerated, you tend to think about people of color. You tend to think about people who are, strong, violent, these and individuals who have considerable mental health issues. And although there's been a reduction in the incarcerated population of about 0.7% per year since 2007, that reduction hasn't occurred equally across all age segments. So in fact, inmates who are age 50 and older, and that's older inmates as defined by the National Institute of Corrections, are actually the fastest growing age segment of the incarcerated population. And that has happened for several reasons, including longer sentences and mandatory minimum sentencing that occurred largely in the 80s and 90s, more arrests that are occurring in later life, and just in general population aging. And so by 2030, older prisoners are expected to comprise approximately 1/3 of the US prison population. So really a large number of people that aren't thought about very frequently. And so in terms of considerations regarding older prisoners and why this population is particularly interesting to me, from a gerontological perspective, older prisoners are said to have accelerated aging, such that they have high rates of chronic medical illness compared with their age-matched peers who live in the community, and their physiological age is then estimated to be about 10 to 15 years greater than their chronological age. And from a psychiatric perspective, older prisoners are a boundaried population, so they're defined by a service setting, and in theory, they can more easily be engaged in prevention because we know kind of where they are and how long they'll be there. Okay. Also of interest to me in terms of my prior research just in older adults living in the community and their mental health, incarcerated persons in mid to later life actually have the highest suicide rates of adult inmates. So when we look at the jail population, you can see that rate per 100,000 jail inmates per year is 72, which is quite high. Here in the prison population, it's 18. Bit lower even than what we find nationally in the community. This is a group that I don't have to preach to the choir about in terms of the greater rates of suicide in older individuals, particularly men. However, in terms of prison, we also do see that. I'm going to come back in a little while too, because obviously there's a big discrepancy between the jails and the prisons. So I'll touch base on that a little later. Okay, and as I was just mentioning, just in general, middle-aged and older adults have consistently higher suicide rates. So you can see in the 75 and older, but these numbers have certainly been growing over the recent years. And despite the growth of the older prison population and as well as their high suicide rates, we really have limited information that exists to inform best practices for early risk detection and suicide prevention in older prisoners. So that's the focus of today. So as Yates mentioned, I really used to focus on the association between disability and mental health in older individuals in the community. And from that research, we've learned that disability and activities of daily living is associated with the onset and the worsening of depression over time, that at least 2 ADL limitations has been found to be associated with a higher likelihood of feeling in the past year that life is not worth living, so death ideation. And instrumental activities of daily living and disability in those have found to be associated with a higher likelihood of suicide among older individuals in the community. So that kind of got me thinking about that relationship and how it might apply to a group of individuals who are aging in place in a setting such as prison. So in terms of instrumental activities of daily living, these measures are really not appropriate for the prison setting. So for example, shopping, planning your meals and preparation, there's really not much decision-making that goes into that when you're incarcerated. In terms of taking your medicine and correct dosages, pretty much you stand and wait for medications to be handed to you, and traveling independently, that's certainly not happening. So really the existing measures for assessing disability cannot be applied in this population. So instead, prisoners have activities of daily living that are actually unique to living in this environment. And those might be climbing on and off a top bunk, walking with handcuffs or shackles, standing in line to get chow or lunch or dinner, and, and standing in line to receive your medications. So these are all unique activities that are really required for life in prison that certainly aren't required for living in the community. And so that brings us to the study that I'm going to talk about in part today, the Aging Inmates Suicidal Ideation and Depression Study, known as Aging Inside. For that study, the objectives of that are to determine factors that are associated with depression and suicidal ideation severity in older inmates, and focusing on disability in those activities that are necessary for managing prison life, so PADLs, prison activities of daily living. And then to determine if deficits in overall physical capacity as well as cognition are useful for identifying older inmates who are at increased risk of depression and suicidal ideation. So the theory behind this, in addition to that relationship that we've seen between disability and mental health in the community, is that kind of whether or not an inmate experiences deficits in physical capacity or cognition is going to in part depend on their environmental considerations. So they certainly live in a unique environment, and that the environment is going to interact with physical capacity and cognition to influence mood. So for example, if there is a real strong environmental demand of prison, such that they feel very unsafe perhaps, and they have low physical capacity, perhaps multiple chronic illnesses and disability, the theory would be that they would be have a higher likelihood of experiencing depression and suicidal ideation. Okay, so in terms of inclusion criteria for the study, I just wanted to highlight that prior to Aging Inside, we conducted a pilot study that then led us to get the larger grant. Our pilot study was in 167 individuals who were incarcerated, and Aging Inside, we were able to recruit 258. There were some similarities between the pilot study and Aging Inside, as I have checked here. Of course, we needed IRB approval. In addition, conducting research with an incarcerated population, you have to have an extra level of approval. So we had to go through the Connecticut Department of Corrections Research Advisory Committee and also get approval from them. In Connecticut, prisoners are not allowed to receive any compensation for participating in studies, as that could be potentially considered to be coercive. So we couldn't offer them anything such as money at the commissary, or we had to let them know that their involvement in the study could no way impact their parole or release time. In the pilot study, we were only in 3 facilities, one women's prison, there's only one women's prison in Connecticut, and 2 other prisons. For Aging Inside, we were across all 9 prisons in Connecticut. We did not include the 3 jail populations that are in Connecticut. This is just focusing on prisoners. They had to be age 50 and older. And the biggest difference between our pilot and Aging Inside was that in Aging Inside, we required the individuals to be sentenced and to have an expected release time of at least 36 months if they were males and 18 months for females. That was in particular because we were focusing on people who were truly aging inside within the prison setting and would be there potentially for at least the year follow-up interview. So we'll talk about how that there were some differences there in the population. This just gives you an idea of our recruitment process. So we started out with 1,083 eligible individuals. 29% completed an interest form. And of course, you would say, well, that's, certainly relatively low. That percentage is about comparable with percentages for participation in male surveys. And this was actually a face-to-face project. So I won't get into it, and we can always talk about it in the discussion, but there are definitely a lot of barriers to actually getting in to speak to individuals who are incarcerated, potential reasons why they would be hesitant to participate in a research study. So we were actually, pleased to get almost 30%. So of those individuals who completed an interest form, 312, we ended up getting 83% of those to participate. Very few women in this group, so only 14 women. So you'll see that most of the results that I present today will really focus on the males. So for data collection for Aging Inside, we conducted face-to-face interviews inside each facility, and those were baseline and 12-month interviews. I'm primarily going to focus on the baseline work today. We also conducted reviews of the Connecticut Department of Corrections data. So that includes things such as, how long they're going to be incarcerated for and whether their offense was a violent offense or not. We conducted medical chart reviews, and that also included utilization review of hospitalizations. So our primary outcomes were suicidal ideation, which we measured using the geriatric suicidal ideation scale. This is participants have to provide their agreement with 30 statements that focus on thoughts, plans, or wishes to hurt themselves, and higher scores indicate higher suicidal ideation. As far as depressive symptoms, we use the PHQ-9. I think most of you are probably quite familiar with that. It assesses depressive symptoms in the past 2 weeks, and participants can rate those symptoms from not at all up to nearly every day. And a score of greater than 10 is typically used to indicate clinically significant depression. And we also conducted clinical interviews for major depressive episode using the SCID. For prison activities of daily living disability, we asked individuals to respond how difficult it was to conduct any of the following 6 activities. And if they responded very difficult or that they couldn't do one of these activities without help, they were included as having PADL disability. So that included dropping to the floor for alarms, climbing on and off the top bunk. I mentioned walking to chow, wearing handcuffs or shackles while walking, hearing orders from staff, and standing in line for medication. And something else that was unique to this study that can't be done certainly through a male assessment was the standardized objective assessments of disability and mobility function. So we evaluated function using the short physical performance battery. That involves assessing gait speed using a 4-meter walk, chair rises, and balance tests. And so each of those tasks is scored from 0 to 4, with a higher score indicating better function. Those who were confined to a wheelchair could not participate. Okay. And other measures that we collected. This was a rather lengthy interview that took around an hour and a half, sometimes up to 2 hours to complete. Some other measures were self-rated health. We assessed neuropsychological function using the MOCA and the TRAILS test, anxiety symptoms, generalized anxiety disorder, or the GAD scale. We also assessed for history of substance use and abuse. We asked about social support and visitation, and also assessed what is known as the social climate, or how they perceived the safety of their situation. So in terms of, I just want to check my time, the sample characteristics, in terms of our pilot and Aging Inside, a fairly comparable mean age. I mentioned there were considerable differences with our pilot and Aging Inside regarding the number of males and females who participated. Primarily males were recruited for Aging Inside, and we think the reason that so few females were involved, it really seemed that additional criteria of having been sentenced and having to stay for quite some time in the prisons, for some reason, those women seemed just less apt to participate than the women who were going to be there for a much shorter time, as was in the pilot study. Aging Inside was also a bit more diverse in terms of the racial distribution. And because, again, of our requirement that individuals had to be sentenced and stay in prison for a certain amount of time, the majority of individuals, or the large majority of individuals in Aging Inside, were incarcerated for a violent offense, so 88%. You can also see they've been incarcerated for a longer number of years, and a higher number of years left to remain in prison. And that doesn't include the 12 participants that have life sentences, because they're essentially coded as 999, so we didn't include them. And for both groups, they were likely to be recidivists, most of them. In terms of contributors to accelerated aging, so I'm just focusing on the males here in Aging Inside. We had over a third who had more than 3 chronic medical conditions. Wanted to highlight a couple of the unique chronic conditions that occur in this population. So hepatitis C and HIV prevalence were fairly high, certainly that as compared with a community sample. Drug use at the time of incarceration was typical. Alcohol dependence, that also 44.6%. We also had quite a few that had head injury. So nearly 60% were reporting a concussion or head injury in their lifetime. Then as far as those who we considered to have PADL disability, about half the sample. And then for the short physical performance battery and poor mobility function, about 14% were performing kind of at a level that's considered, clinically problematic. So a score of less than or equal to 9. So just in terms of the depressive symptoms, wanted to highlight that one might think, okay, if you're old and you're in prison, you're sentenced, you're going to be there for quite some time, of course, you're going to be depressed. However, there is opportunity for intervention, such that we found just a bit less than a quarter of the sample actually reached the criteria for clinically significant depressive symptoms based on the PHQ-9. As far as having a current major depressive episode, here about 12.5%. And of course, though, the percentage of lifetime suicide attempt was incredibly high. So nearly 30% of our sample was reporting having attempted suicide in the past. And again, knowing that depression and suicide attempt are really the strongest predictors of subsequent suicide, there definitely is opportunity for intervention here. And as far as the average suicidal ideation scores, I just wanted to give you an idea of the difference. And I apologize, the standard error bars didn't make it onto this slide. But comparing the men in Aging Inside to a community sample of older men, about 50 and older, you can see that there are really considerable differences in the average GSIS scores across these samples. Wanted to highlight as well that within the older incarcerated population, there really is a lot of heterogeneity. And one way that they are heterogeneous is the amount of time that they've spent in prison. So some individuals may have just been incarcerated for the first time at age 50 and older. Others are recidivists who have come, in and out of prison frequently throughout their lives. And then there's the others that have truly aged in place in prison and spent the majority of their lives incarcerated. So I recently worked with a medical student from UCSF who wanted to look at the impact of having a life sentence among people who had truly aged in place in prison. So we looked at the individuals, so there were 65 in the study, who had already spent 20 years incarcerated, and then splitting those up into those who were expected to be released within the next 20 years and those who had a life sentence or really were expected not to be released. And as you can see, even within this group who had aged in place for the same essentially amount of time, we still found some significant differences both in their physical functioning as well as in their mental health. So kind of that notion that one is never going to be out of prison or is likely to die in prison seemed to have definitely some impact. I think in particular, when we look at the GSIS scores, there's definitely a considerable difference between those. So kind of back to the prison activities of daily living, I'm actually presenting data that came from our pilot study, but really we found very similar results in Aging Inside, but I had these readily available. So after considering other characteristics that are associated with depression, such as number of chronic conditions and chronic pain and lifetime suicide attempt, even after considering those factors, PADL disability was 3.9, people with PADL disability were 3.9 times more likely to experience depression than were those that were not reporting the disability in these prison activities of daily living. Then in terms of suicidal ideation, we also found that PADL disability in the unadjusted model was associated with suicidal ideation, such that those reporting PADL disability had scores that were nearly 10 points higher than those not reporting the disability. Now, granted, when we controlled for the other factors, if you look at the confidence interval in the adjusted model, it's no longer significant. However, this 7.3 difference in a mean score is still certainly clinically significant in terms of a difference. So still giving us information that PADL disability could be a significant risk factor for suicidal ideation. Then more recently, we also looked at the association between the objective functional disability and suicidal ideation, and perhaps, not unexpectedly, depression is largely mediating that relationship between the disability and suicidal ideation scores. So if someone is reporting functional disability or objectively is showing physical disability, seems that that is leading to the depression, which then leads to suicidal ideation, which one certainly would expect. We also were able to control, though, for a lifetime suicide attempt and whether or not they were receiving mental health treatment. So again, kind of leads us to a factor preceding the depression that certainly might be able to be intervened upon. And this, I just wanted to let you know, as far as, I said I was focusing mostly on the cross-sectional associations. We're in the process of evaluating the data from the follow-up, the one-year follow-up, and preliminary information is showing us that the PADL disability is predictive of depression 1 year later. So you can see that by the odds ratio here. And again, that's also controlling for baseline depression, which clearly has a strong relationship whether one is depressed 1 year later. But we're still seeing that PADL disability as a considerable risk factor. So in terms of this research, what we're concluding is that identifying older prisoners with PADL disability may distinguish those that have a higher likelihood of being depressed or experiencing more severe suicidal ideation. So this study is really providing a necessary first step towards both improving and informing the best practices for suicide prevention for this rapidly growing population. And importantly to note, suicide risk in inmates is really only assessed at intake. Intake meaning, when they are admitted essentially to when they are first incarcerated. And that only occurs unless there is a referral. So either by the prisoner themselves referring themselves to mental health, or if there's another inmate who is concerned about someone. So, suicide risk assessments aren't going on regularly. So disability really provides a means of identifying those who might be at higher risk. And our findings provide support for prison-based interventions that might target functional disability. So perhaps geriatric housing, for example, that are considerably upstream from suicide. And some things to consider, though, as we think about these interventions, are that right now there are rules essentially through the ADA that prisoners need to be in integrated settings. However, this balance might become much more difficult as the older prison population grows, and there's going to be quite a bit of difference in terms of disability in these groups. Now, I just wanted to jump attention a bit to COVID-19 on the inside. It's hard to certainly ignore right now and how that impacted our study. So on March 13th of 2020, all in-person research and social visits in Connecticut prisons and jails stopped. And the first known inmate to test COVID positive occurred on March 30th. So at that time, the Connecticut Department of Correction employees were required to then pass a wellness screen before being able to go to work. I don't actually have information on exactly what that wellness screen had as part of it, and one can assume, temperature checks. Then in terms of the inmates, any inmates who were either exposed to COVID or were displaying symptoms were moved to isolated areas. And you think about issues related to solitary confinement and mental health related to solitary confinement. And you can think about being incarcerated and essentially being put in solitary confinement because of a particular illness. And inmates who tested positive were also moved to either a specified dorm or they were moved to a different facility. So they were literally moved to one facility in particular, which is known to house the most violent, most serious prisoners, basically in terms of offense. So move to another location. So certainly, could have some implications on mental health. Okay. So given that we were unable to go in and conduct our face-to-face interviews, and we had completed, of the 258 individuals that we recruited, we completed just, I believe it was about 210, 220 one-year follow-up interviews. But so we had to stop because of COVID-19. So instead, we opted to send letters to the 202 Aging Inside participants who were still incarcerated. Several, reasons why we weren't able to send it to all 258 is due to some were released or paroled. We had 7 that had been released early because of COVID-19 related circumstances, and then others transferred to a different facility or had died. And we asked those individuals if they would like to participate in an Aging Inside check-in study. And from that, from the 202 people that we sent letters to, we got participation of almost 78%. And so just briefly, just wanted to show you again, likely what we would expect, since we all probably experienced some of this. However, of course, being in a carceral setting might have some other implications. So this shows depressive symptoms using the PHQ-9 prior to COVID and then during COVID. So of course, prior to COVID, you can see that 60% of people only had minimal depressive symptoms. However, upon year when COVID was really involved in got into the prisons, you had significantly fewer individuals reporting minimal depressive symptoms. And you can see that in all of the other categories after COVID, or I should say during COVID, those percentages went up. And we saw something fairly similar for anxiety symptoms as measured with the GAD as well. So more people experiencing minimal symptoms, prior to COVID, and then afterwards, we really see that shift, and particularly in those experiencing severe anxiety symptoms. So we really saw a jump there from about 10% up to a quarter of the sample. So certainly COVID-19 is having an impact inside the prisons as well, as one can imagine. So now I just wanted to shift to what happens after incarceration. So we know that while these older individuals are incarcerated, there's a certain proportion who are definitely experiencing depression, experiencing anxiety symptoms, and that seems to definitely be increasing given COVID-19, and we will be continuing to follow these individuals so that we can chart what is going on with them while they're still incarcerated. But we're also interested as to, well, what happens to these individuals after incarceration? So the majority of people who are incarcerated are eventually released to the community. So about 95% either get to the end of their sentence or they're on parole or probation. And given the increasing numbers that we're seeing of people who are incarcerated and are aged 50 and older, the number of people who should be transitioning from incarceration to the community in middle and older age can also be expected to grow. And here we're having a convergence of factors. So it is already known that the transition from prison to community is associated with high risk of suicide and unintended death. So that's kind of across a mixed age sample. And as we discussed earlier, that people who are in mid to later age have the highest suicide rates. And we're also seeing increasing rates of death by drug overdose in that group. In particular, the largest rate increase in opioid-related deaths in recent years has been among those aged 55 to 64. So now you have those kind of two factors coming together with older persons who are being released to the community in growing numbers. Now, in terms of prior research, as I mentioned, prior studies had evaluated transition from prison to the community as a risk factor for negative outcomes. However, they've largely been unable to evaluate suicide attempt, which of course we know that suicide attempt is then a very strong or the strongest risk factor for subsequent death by suicide. They were unable to use a national sample to quantify risk. And they did not quantify risk in later life, even though that we know individuals who are middle to later age have a higher risk of suicide in general. So we decided to focus on additional research questions, not using the Aging Insights study, but using VA data, which I'll just talk about in a moment, and focus on, is the transition from prison to community in later life a risk factor for suicidal behavior and death by drug overdose or accidental injury? And we're also focusing on our healthcare service use patterns following prison release related to suicidal behavior in this group. So we conducted a retrospective cohort study using administrative data from Medicare eligible veterans who were age 50 and older and had been incarcerated between 2012 and 2014. And we followed them from their most recent prison release until death or study completion. And we also had a matched sample of never incarcerated veterans who are matched by age, year of that correctional facility release, and the various other factors that you can see there. And in terms of data, we had data from CMS, so Medicare claims data was used to identify the prison release and admission dates. So there's codes that are available that let you know if someone is no longer eligible for Medicare because they've been incarcerated, or then otherwise Medicare is reinstated, once they're discharged from prison. We also had access to several databases from the VA, the National Care Database, which provides information on in and outpatient VA services, and then the SPAN, the Suicide Prevention Applications Network, as well as the National Suicide Data Repository. What's really unique about SPAN is that the VA collects very detailed data on suicide attempt. And then we were also able to get the cause-specific death data from the SDR. So we really had a rich data set to evaluate these questions. Just in the interest of time, I'm just going to skip over the analyses, but I'd be happy to answer questions about that. In terms of the sample characteristics, the re-entry sample and this is the age-matched sample. So just wanted to kind of show you in terms of the matching that people are similar. However, with psychiatric illness, 84% had any psychiatric illness. Homelessness was considerably higher in the reentry population. Traumatic brain injury, about double the prevalence, and they also had a higher average number of chronic conditions. Just in terms of the re-entry sample, on average, they had spent 1.3 years in prison. However, there's a huge range there, ranging from 1 day to nearly 37 years that they'd already been in prison. 19% had more than 2 incarcerations during the years that we were focusing on, and 48% had at least 2 incarcerations in their lifetime. So as far as the cumulative incidence of both suicide attempt and injurious death, these figures show that at any given age, the re-entry group has a higher incidence of both suicide attempt as well as injurious death overall. So regardless of what age you're considering, reentry was a factor. And then looking at the hazard ratios here, focusing on the reentry group as compared with the never incarcerated. Those who are reentering the community after adjustment had 3.45 times the risk, essentially, of experiencing a suicide attempt as compared with their never incarcerated peers. We also saw significant relationships between reentry and death by accidental overdose, as well as death by accidents other than drug overdose. In terms of suicide, there was double the risk. However, this was not significant once adjusting for those additional factors mentioned. So in terms of those findings, we found that veterans transitioning from prison to the community in later life were more than had 3 times greater risk of suicide attempt, death by drug overdose, and death by other accidents compared with their never incarcerated peers. And these findings were clinically meaningful. So that really translates to an additional 465 suicide attempts and 157 deaths by accidental overdose or other accidental injury per 100,000 person years. So certainly opportunity for intervention there. But we did not see that suicide mortality rates were observed to be quite different. Limitations of some of this. So we didn't have information on whether these individuals had tried to attempt suicide or what certain behaviors were during their period of incarceration. We only had information afterwards. Here as I mentioned, we don't have data regarding the reason for incarceration or other factors that could influence these relationships, like social support or employment status. And again, it's possible that there was some misclassification. And because our sample was largely male and it was all veterans, this generalizability might be limited. From there, and I want to give a chance for questions, so I'll go through this very quickly, but we were able to increase the data set and focus on if transition from prison to the community was also a risk factor for substance use related hospitalization and emergency room visits. So, so here we conducted 1 to 5 matching, and we actually, well, here I say age 18 and older. I'm going to present data focused on age 15 and older. But what we were able to do is to determine substance use disorder history in the 3 years prior to incarceration, because we focused on those who had been incarcerated for 5 years or less. So that way we could control for substance use disorder history. And again, we used a matching sample of those who were never incarcerated. Just in terms of the prevalence very quickly, you can see that the prevalence of any of these outcomes, so any substance use disorder related hospitalization or ED visit, and given these specific reasons, the prevalence was considerably higher in the reentry sample as compared with the never incarcerated sample. And just so you can see the, oops, I'm sorry, this says never, these are the ends for each, but this is the adjusted results. So comparing again, the reentry group to the never incarcerated group. So without adjustment, individuals who are in the reentry group were more than 6 times more likely to experience a substance use disorder related hospitalization or ED visit in the first year after they were released from incarceration. That did go down certainly after adjustment, but still remained significant. And I provided the information on alcohol, cocaine, and opioids specifically because those were really the 3 specific substances where we saw the greatest risk. And we also found that that risk was especially high in the first 30 days after they transitioned from prison. So still significant risks afterwards, but that 30-day mark really shows a high risk of those events. So our conclusions, this was the first study that we used national data to quantify risk of these outcomes. And again, in this population that's growing considerably. And our findings are complementing the growing body of research, emphasizing the importance of care transitions to suicide risk and prevention. So certainly this has important implications for care transition models, that when patients are transitioning from one setting to another, there can be high risk for these outcomes. And targeting suicide and substance use disorder prevention efforts towards this transition may ultimately help to reduce the number of older veterans who are dying by suicide and also experiencing related adverse outcomes. So in terms of wrapping up, so conducting research with older incarcerated persons is challenging, yet not impossible. And we were also able to utilize administrative data, which really has opened up the possibilities of understanding the impacts of incarceration and reentry. The mental health of older justice-involved populations are very important, with implications both on the inside, within the prisons and jails, and the outside. And there are definitely opportunities to intervene, but much more research is needed. And in particular, if you think back to, I showed you right at the beginning of our talk that the individuals incarcerated in jails have a very high rate of suicide. That's one opportunity really for transitions in care, where a lot of research needs to be done and interventions are needed. And so I just wanted to acknowledge my funders. And let's see, the American Foundation for Suicide Prevention, NIMH, and of course the Department of Correction, my research team, and other co-authors. That includes Dr. Conwell, and certainly the UConn Center on Aging and Department of Psychiatry. And that's all I have for today. So.
Thanks so much, Lisa. There's so much there. We do have time for a few questions. And first of all, just want to acknowledge how difficult this kind of work is to do, and how amazing it is that your team has been able to establish the partnerships necessary in both studies, but primarily with the correction system in Connecticut to make this go. It's just very important and very impressive. Mm-hmm. One question, and I encourage people to put more into the box. We'll do the Q&A box the best we can to answer them. This is from Eric Kane. It seems that the pattern of suicides among veterans leaving prisons is similar to those leaving domiciliary settings. Is that your impression? And domiciliary settings being like residential, long-term care or rehabilitation facilities in the VA. What's your thought about that?
Oh, that's an interesting thought. I mean, sometimes people will try to compare the two settings, and I think that they're definitely very different places, although one could argue that there are some common factors between being in a domiciliary setting and an incarceral setting. I think that's certainly an area of future research to see if potentially some of those common factors, whether they are, lack of visits or just that care transition and perhaps lack of continuity of care, it really seems like that is the common ground between those, that maybe it doesn't matter so much where you were before as to how much communication is going on during that transition phase. So, that's definitely an area of exploration, but I think it's really showing that care transition, and particularly, again, focusing on those first 30 days after transition where the risk is so high, something is going on there that definitely needs to be improved upon. And I think that's maybe where we could perhaps use similar interventions across those different settings.
Thank you. Another question related in a way. Has any research been done on available housing, work, and healthcare for formerly incarcerated prisoners related to suicidal ideation?
Within the VA, and they're certainly unique, they have a particular focus on trying to help individuals who are transitioning from prison to the community. So they do have perhaps more outreach efforts, being a veteran than you would otherwise. I'm not sure if there is literature that focuses really on the implications of having housing and, like you said, employment. I think some of those issues are particularly important to this group of older prisoners because, again, just because of their age, you could imagine if one has been in prison for 30 years, you may have lost a lot of your contacts outside of prison, so your social support may not be available. It also, just in general, because of age, would be harder to get a job. So that's definitely, I think, another area of research that I'm not aware if there is something that exists there to really look at suicidal ideation in those people afterwards and see if some of those factors have a difference or not. A lot to be done.
So much to be done. And while there are a number of additional questions, I'm sorry we're not going to be able to get to since we're out of time and respecting people's need to get to the next meeting.
Sure.
We're going to need to stop now. But again, thank you so much, Dr. Barry, and congratulations on great work. Really appreciate you sharing it with us.
Thank you. And if you send me those questions, I'd be happy to answer them offline in email or anything. And please have people email me if they wish. So
very good.
Thank you very much.
Thank you. All right, that's it for today. Thank you, everybody.
Okay, thank you.